Today we start talking about deep vein thrombosis. Deep vein thrombosis is an obstructive disease with hindering venous reflux mechanism. There in the picture you see the normal anatomy of the veins. And you see femoral vein, you see the posterior tibial veins, you see the great saphenous veins, anterior tibial veins, and popliteal vein. DVT usually involves the lower limb venous system with clot formation, originating in a deep calf vein and propagating proximally. There you see the reason why we have the problem with deep vein thrombosis and how it looks like. It is a common venous thromboembolic disorder with an incidence of 1.6 per 1,000 annually. The rate of particular site involvement depends on the anatomical location as follows: distal veins 40%, popliteal 60%, femoral 20%, common femoral 20%, and iliac veins 4%. Deep vein thrombosis is a blood clot that forms within the deep veins, usually of the leg, but can occur in the arms and the mesenteric and cerebral veins. Deep vein thrombosis is a common and important disease. It is part of the venous thromboembolism disorders, representing the third most common cause of death from cardiovascular disease after heart attacks and stroke. Even in patients who do not get pulmonary emboli, recurrent thrombosis and post-thrombotic syndrome are major cause of morbidity. Deep vein thrombosis is a major medical problem, accounting for most cases of pulmonary embolism. Only through early diagnosis and treatment can the morbidity be reduced. Etiology. We have talking there of risk factors and increased risk of coagulation. Following are the risk factors that are considered causes of deep vein thrombosis: reduced blood flow, immobility, bed rest, general anesthesia, operation, stroke, long flights, increased venous pressure, mechanical compression, or functional impairment, leading to reduced flow in the veins, neoplasm, pregnancy, stenosis, or congenital anomaly which increase outflow resistance, mechanical injury to the vein, trauma, surgery, peripheral inserted venous catheters, previous DVT, intravenous drug abuse, increased blood viscosity, polycythemia rubra vera, thrombocytosis, dehydration, and anatomic variation in venous anatomy can contribute to the thrombosis. Increased risk of coagulation, genetic deficiencies, anticoagulation, protein C and S antithrombin 3 deficiency, factor V Leiden mutation, acquired cancer, sepsis, myocardial infarction, heart failure, vasculitis, systemic lupus, erythematosus, and lupus anticoagulant, inflammatory bowel disease, nephrotic syndrome, burns, oral estrogens, smoking, hypertension, diabetes. Obesity, pregnancy, the advanced age of older than 60, surgery, critical care admission, dehydration, and cancer are the established causalities of DVT and VTE. Obesity is associated with a hypercoagulability status via two mechanisms: increased fibrinogen levels that may even surpass twofold the normal value, and slower venous circulation flow in the infradiaphragmatic and especially in the lower limbs. Both factors associated with disorders and several coagulation factors favor the appearance of venous thrombosis, thrombophlebitis, and thromboembolic events, and mostly fatal pulmonary thromboembolism, which are the primary cause of mortality in obese patients. Potential risk factors of deep vein thrombosis might be categorized according to the transient, persistent, or unprovoked criteria. Accordingly, transient risk factors are as follows: surgery with general anesthetics, hospitalization, caesarean section, hormone replacement therapy, pregnancy and peripartum period, lower extremity injury with limited mobility for more than 72 hours. It should be noted that general anesthesia for longer than 30 minutes and hospitalization for longer than 32 hours is considered the transient risk factors of DVT. However, active cancer and specific medical conditions that increase the risk of venous thromboembolism are categorized as persistent risk factors. Systemic lupus erythematosus and inflammatory bowel disease are among the predisposing medical conditions. Any further etiological risk factors not categorized among either transient or persistent subgroups should be labeled as unprovoked venous thromboembolism. For instance, a recent cohort study, including 500 participants, evaluating the association of blood lipid levels and lower extremity DVT, demonstrated that higher total cholesterol levels, high density lipoprotein, and apolipoprotein A1 were associated with a decreased risk of lower extremity DVT. Lower high triglyceride levels were associated with a greater risk of lower extremity DVT. Deep vein thrombosis and pulmonary emboly are common and often silent, and thus go undiagnosed or are only picked up at autopsy. Therefore, the incidence and prevalence are often underestimated. It is thought the annual incidence of DVT is 80 cases per 100,000, with a prevalence of lower limb DVT of 1 case per 1,000 population. Annually in the United States, more than 200,000 people develop venous thrombosis. Of those, 50,000 cases are complicated by pulmonary embolism. Epidemiology. Age. Deep vein thrombosis is rare in children and the risk increases with age, most occurring in the over 40 age group. Gender. There is no consensus about whether there is a sex bias in the incidence of DVT. Ethnicity. There is evidence from the United States that there is an increased incidence of DVT and an increased risk of complications in African Americans and white people compared to Hispanics and Asians. Associated disease. In the hospital, the most commonly associated conditions are malignancy, congestive heart failure, obstructive airway disease, and patients undergoing surgery. And maybe there we can tell about patients who use hormone therapy. Pathophysiology. According to Virchow's triad, the following are the main pathophysiological mechanisms involved in DVT: damage to the vessel wall, blood flow turbulence, and hypercoagulability. All of these give us a thrombosis. The Virchow's triad is something that you will use everywhere. Please remember in this one that we have the damage of the vessels, the blood flow turbulence, and hypercoagulability. Pathophysiology. Thrombosis is a protective mechanism that prevents the loss of blood and seals of damaged blood vessels. Fibrinolysis counteracts or stabilizes thrombosis. The triggers of venous thrombosis are frequently multifactorial, with the different parts of the triad of Virchow contributing in varying degrees in each patient, but all result in early thrombus interaction with the endothelium. This stimulates local cytokine production and causes leukocyte adhesion to endothelium, promoting venous thrombosis. Depending on the relative balance between the coagulation and thrombolytic pathways, thrombus propagation occurs. DVT is commonest in the lower limb below the knee and starts at low flow sites such as the soleal sinuses behind venous valve pockets. A potential correlation between DVT and atherosclerosis has been proposed. The endothelial dysfunction involved in the pathophysiological mechanism of DVT will potentially result in AS, atherosclerosis. Accordingly, a greater risk of subsequent AS in patients with DVT is predicted. Histopathology. In the venous system following acute thrombosis formation, an extensive remodeling process occurs. Neutrophils and macrophages infiltrate the fibrin clot from within the lumen of the vessel over weeks, leading to cytokine release and eventually fibroblast and collagen replacement of fibrin. This remodeling and fibrosis can result in diminished blood flow long after the acute thrombosis resolves. The clinical presentation of acute lower extremity DVT varies with the anatomic distribution, extent and degree of occlusion of the thrombus. Symptoms may range from absence to massive swelling and cyanosis with impending venous gangrene. Three patterns of thrombosis are usually recognized: isolated calf vein, distal, femoropopliteal, and iliofemoral thrombosis, and symptoms tend to be more severe as thrombosis extends more proximally. However, up to 50% of patients with acute DVT may lack specific signs or symptoms. Postoperative patients are in particular more likely to have small, asymptomatic, distal, non-occlusive thrombi. When present signs and symptoms of acute lower extremity DVT may include pain, edema, erythema, tenderness, fever, prominent superficial veins, pain with passive dorsiflexion of the foot, as this is the common sign, and peripheral cyanosis. Phlegmasia cerulea or cerulea dolens, characterized by the triad of massive swelling, cyanosis, and pain, in the most severe form of acute lower extremity DVT and results from complete thrombosis of an extremity's venous outflow. In advanced cases, it is marked by severe venous hypertension with collateral and microvascular thrombosis leading to venous gangrene. Venous gangrene is particularly associated with warfarin-mediated protein C depletion in patients with cancer or heparin-induced thrombocytopenia. Obtaining the diagnosis of DVT only based on clinical signs and symptoms is notoriously inaccurate. The signs and symptoms of DVT are generally non-specific. They may be associated and misdiagnosed with other lower extremity disorders. Accordingly, lymphedema, superficial venous thrombosis, and cellulitis should be excluded. Oh, and there I think you need exclude one more disease, lipedema. We have lymphedema and lipedema. Lipedema is the youngest disease. When I do this presentation, I don't know about this disease. History and physical. However, the most common presenting symptoms with inconsistent sensitivity and specificity are calf pain and swelling. The former index has a sensitivity of 75 to 91% and the specificity 3 to 87%, and the later might have a sensitivity of up to 97% and a specificity of up to 88%. None of the signs or symptoms is sufficiently sensitive or specific either alone or in combination to accurately diagnose or exclude thrombosis. In history, you can find pain, redness, and swelling. In physical examination, you will find lymphedema, maybe in unilateral or bilateral if the thrombus extends to pelvic veins. Red and hot skin with dilated veins. Tenderness. Evaluation. The following veins are categorized as deep vein according to the Clinical Etiology Anatomy Pathophysiology CEAP classification. Inferior vena cava, common iliac, internal and external iliac pelvic veins, including a gonadal and broad ligament veins. Common femoral deep femoral vein, femoral popliteal, paired crural veins of anterior and posterior tibial and peroneal, muscular veins of gastro, cranial, and sodal. And there you see the anatomy. External iliac vein, femoral vein, Perforating veins, yes, it's the veins between the deep and superficial veins. Great saphenous vein, small saphenous vein, there, and anterior tibial vein, posterior tibial vein, and dorsal venous arch. As per the National Institute for Clinical Excellence, NICE, guidelines, following investigation are done. The dimers, very sensitive but not very specific. Calculation profile, proximal leg vein ultrasound, which when positive indicates that the patient should be treated as having a DVT. Deciding how to investigate is determined by the risk of DVT. The first step is to assess the clinical probability of a DVT using the Wells scoring system. Wells scoring system you see in the right side. Yes, DVT signs 3 points, DVT of P history 1.5 points, heart rhythm more than 100 minutes 1.5 points, recent surgery of embolization less than 4 weeks 1.5, hemoptysis, cancer, alternative diagnosis less likely than pulmonary embolism. Yeah, and there you see low, intermediate, high, pulmonary unlikely, pulmonary likely. Score less than 2 points to 6, more than 6, less than 4 points, more than 4 points. And there you see the percent of probability of pulmonary embolism with the percent with the score. Yeah, and 5 points how you need to check the Wells scoring system. The clinical probability is low for patients with a score of 0 to 1, but for those with 2 or above, the clinical probability is high. If a patient scores 2 or above, either a proximal leg vein ultrasound scan should be done within 4 hours, and if the result is negative, a dead dimer test should be done. If imaging is not possible within 4 hours, a dead dimer test should be undertaken, and an interim 24 hours dose of a parenteral anticoagulant should be given. A proximal leg vein ultrasound scan should be carried out within 24 hours of being requested. In the case of a positive D-dimer test and a negative proximal leg vein ultrasound scan, the proximal leg vein ultrasound scan should be repeated 6 to 8 days later for all patients. If the patient does not score 2 on the DVT Wells score, but the D-dimer test is positive, the patient should have a proximal leg vein ultrasound scan within 4 hours, or if this is not possible, the patient should receive an interim 24 hours dose of a parenteral anticoagulant. A proximal leg vein ultrasound scan should be carried out within 24 hours of being requested. In all patients diagnosed with DVT, treat as if there is a positive proximal leg vein ultrasound scan. Clinical decision rules such as the pulmonary embolism rule out criteria, PERC, and the Wells criteria should be employed with the patient presenting with possible DVT. Risk stratification is crucial in deciding diagnostic and management options. Patients who meet PERC criteria may need no further testing, whereas those who do not meet PERC criteria and are low probability based on the Wells criteria may be candidates for rule out with a D-dimer. The D-dimer test is sensitivity but not specific and should be used selectively in low probability patient who does not have other confounding diagnoses that could produce a false positive test. The test also should be used with caution, perhaps with different cutoff values in the elderly. Yeah, and there in the picture you see the dimer will high if you're more than 60 years old, you recently had surgery, you have severe liver disease, you have sickle cell disease, you smoke. Yeah, that means why we when we talk about the D-dimer test, we don't talk about specificity. Imaging modalities available to evaluate for DVT include diagnostic ultrasound, vascular studies, CT venograms, and point-of-care ultrasound (POCUS). Rapid diagnosis or rule out by the emergency provider can expedite necessary treatment and reduce the length of stay, and it is particularly useful when access to 24 hours ultrasound is unavailable. There is evidence that emergency practitioners can perform a two-point compression exam at the two highest probability sites for identifying a DVT, femoral and popliteal veins. However, recent literature suggests a two-region approach where clinicians do serial compression testing may significantly improve diagnostic sensitivity without greatly increasing diagnostic time. This point-of-care ultrasound exam should be used with other clinical decisions rules and is perhaps most useful in those patients with high and low pretest probability. With the patient supine in the frog-leg position, apply approximately 20 to 30 degrees of reverse Trendelenburg to increase venous distension. That means that we need to have patient's head upper than the legs. Place the high-frequency linear transducer in the transverse plane at the anatomical location of the inguinal ligament. Just distal to the inguinal ligament, the common femoral vein can be visualized. Apply direct pressure to the vein. The complete collapse of the vein indicates there is no presence of a DVT. Continue distally along the femoral vein to where the greater saphenous vein and deep femoral vein deviate from the common femoral vein. Complete compression of all venous structures at this level rules out a proximal DVT. Next, produce to the popliteal region. Laterally rotate of the leg, flex the knee, and place the higher frequency transducer transversely in the popliteal fossa. The popliteal vein typically resides just anterior to the popliteal artery. Apply a compressive force once again and observe for complete compression. Compress the areas just proximal and distal to the popliteal fossa as well to complete the two-region technique. If DVT studies are negative, repeat testing may be required in 1 to 2 weeks to rule out a propagating calf DVT further. Alternatively, sending a D-dimer test may be adequate in certain patient population. And there you see the picture of the ultrasound. There we visualize interluminal thrombus, and there you see how it looks like if we draw in the veins and then artery. And there inability to compress vein completely. We can't compress and don't will closed, don't be sickness, and the reason is the thrombus. Typical laboratory tests also should be sent to evaluate for coagulation status, blood count, and renal function. Treatment of DVT aims to prevent pulmonary embolism, reduce morbidity, and prevent or minimize the risk of developing post-thrombotic syndrome. The cornerstone of treatment is anticoagulation. NICE guidelines only recommend treating proximal DVT and those with pulmonary emboly. In each patient, the risk of anticoagulation need to be weighed against the benefits. Treatments of DVT should be addressed mainly according to the underlying causality of DVT as follows. Look, there will be 10 points what you need to remember. The preferred anticoagulant to address DVT in cancer-associated thromboembolism is low molecular weight heparin and factor 10A inhibitors, including rivaroxaban. However, in the following circumstances, the high levels of anticoagulation should be considered. First of all, recently diagnosed cancer. Second one, extensive VTE circumstance. And third one, cancer treatment-related adverse effects including vomiting. Second point, in circumstances where only daily oral therapy is the preferred management, the following options are viable: rivaroxaban, edoxaban, and vitamin K antagonist. In the context of liver disease, DVT should be managed with low molecular weight heparin. Direct oral anticoagulants are contraindicated in raised inner levels. In patients with renal disease, suppressed creatinine clearance to the less than 30 ml per minute, vitamin K antagonists are recommended. DOACs and LMWH should be avoided in patients with end-stage renal disease. In patients with a remarkable past medical history of coronary artery disease, the following alternatives are recommended: vitamin K antagonism, rivaroxaban, apixaban, and edexaban. And patients with remarkable dyspepsia or any past medical history suggestive of gastrointestinal bleeding, vitamin K antagonism and apixaban are the preferred treatments. It should be noted that DOCAs, dabigatran, factor Xa inhibitors, rivaroxaban, and selective factor Xa inhibitors, edexaban, might be associated with higher rates of gastrointestinal bleeding. In the group of patients with a history compatible with poor compliance, vitamin Ka is preferred. However, it should be noted that still some patients might be highly compliant with other alternatives, including DOACs. If thrombolytic therapy is indicated, infractionated heparin is indicated. In patients who might later be subjected to reversal of thrombolytic therapy, it should be noted that reversal agents for DOACs are not universally available. And the last point, since most anticoagulants have the potential to cross the placenta, their preferred anticoagulation therapy during pregnancy is LMWH. Look, don't worry if you don't understand this topic now and the treatment now, because I need to tell you that I understand this topic just in my first year of residence. Moreover, the following guidelines address the required duration of treatment. Low molecular weight heparin for fondaparinux for 5 days or until INR is greater than 2 for 24 hours. Infractionated heparin for patients with renal failure and increased risk of bleeding. Vitamin K antagonist for the 3 months. In patients with cancer consider anticoagulation for 6 months with lower molecular weight heparin. In patients with unprovoked DVT consider vitamin K antagonism beyond 3 months. Rivaroxaban is an oral factor Xa inhibitor which has recently been approved by the FDA and NICE and is attractive because there is no need for regular INR monitoring. In the platelet count drops to less than 7,500, switch from heparin to fondaparinux, which is not associated with heparin-induced thrombocytopenia. Thrombolysis. The indications for the use of thrombolytics include symptomatic iliofemoral DVT, symptoms of less than 14 days duration, good functional status, a life expectancy of 1 year or more, low risk of bleeding. The use of thrombolytic therapy can result in an intracranial bleed, and hence, careful patient selection is vital. Recently, endovascular interventional interventions like catheter-directed extraction, stenting, or mechanical thrombectomy have been tried with moderate success. Compression hosiery. Below knee graduated compression stocking with an ankle pressure greater than 23 mm for 2 years if there are no contraindications. Inferior vena cava filters if anticoagulation is contraindicated or if emboli are occurring despite adequate anticoagulation. Rivaroxaban, apixaban, dabigatran, edexaban, and betrixaban are relatively newer factor Xa inhibitors approved for prophylaxis of deep vein thrombosis. The duration of DVT treatment is 3 to 6 months, but recurrent episodes may require at least 12 months of treatment. Patients with cancer need long-term treatment. Inferior vena cava filters are not recommended in acute DVT. There are both permanent and temporary inferior vena cava filters available. These devices may decrease the rate of recurrent DVT but do not affect survival. Today, only patients with contraindications to anticoagulation with an increased risk of bleeding should have these filters inserted. Differential diagnosis: cellulitis, post-thrombotic syndrome, especially venous eczema and lipodermatosclerosis, ruptured Baker cyst, trauma, superficial thrombophlebitis, peripheral edema, heart failure, cirrhosis, nephrotic syndrome, venous or lymphatic obstruction, arteriovenous fistula, and congenital vascular abnormalities, vasculitis. Given the increased risk of thromboembolism, patients with clinically active malignancy would benefit from thromboprophylaxis. A meta-analysis looking at a total of 33 trials and 12,000 patients provided more evidence that thromboprophylaxis decreased the incidence of VTE in cancer patients who were undergoing chemotherapy or surgery, while no apparent increase in the incidence of significant bleeding. Current guidelines from the National Comprehensive Cancer Network recommended anticoagulation with infractionated heparin or lower molecular weight heparin in hospitalized cancer patients as thromboprophylaxis. Mechanical prophylaxis should be used instead of anticoagulation therapy in patients experiencing active bleeding, thrombocytopenia, platelet count below 500 mcl, evidence of hemorrhagic coagulopathy, or having an unilateral catheter. Contraindications to mechanical prophylaxis include acute deep venous thrombosis and severe arterial insufficiency. A recent meta-analysis addressed the question of the optimum duration of anticoagulation in cancer patients hospitalized with acute illnesses. This study looked at trials comparing standard duration versus extended duration anticoagulation prophylaxis. The risk of VTE was not significantly lower in the extended duration prophylaxis group of patients, but the risk of bleeding was about two-fold higher. Regarding outpatient VTE prophylaxis, surgical pelvic or abdominal oncology patients would benefit from continuing VTE prophylaxis up to 4 weeks post-operation. The use of aspirin or anticoagulation therapy for patients with multiple myeloma on immunomodulatory medications is recommended based on risk stratification with the IMPET VTE score. For patients with solid cancer on chemotherapy and high Corona score, prophylactic anticoagulation with direct oral anticoagulation or lower molecular weight heparin showed a decrease in the incidence of pulmonary embolism. Lower molecular weight heparin remains the preferred anticoagulation option for managing cancer-associated thrombosis. The dosage recommendation for LMHH is 1 mg per kilogram every 12 hours and 1 mg kilogram once daily for patients with creatinine clearance of less than 30 ml in minute. Avoid the use of LMHH in patients on dialysis. Other treatment options include direct oral anticoagulants like apixaban, rivaroxaban, and etixaban, fondaparinux, and warfarin. In the Caravaggio trial, research found apixaban to be non-inferior to LMHH in treating cancer-associated VTE without an increased risk of significant bleeding. Thrombolytic therapy can be used in patients with live or limb treating pulmonary embolism or acute deep vein thrombosis, considering contraindications such as intracranial tumors or metastasis, active bleeding, and a history of intracranial hemorrhage. NCCN recommends a treatment duration minimum of 3 months or for the duration of active malignancy. For patients with non-catheter-related deep venous thrombosis or pulmonary embolism, identify anticoagulation is the recommendation. Continuing to assess for benefits versus risks as well as monitoring for complication is essential. In patients with DVT located in the inferior vena cava, iliac, femoral, and popliteal veins, in addition to a contraindication to therapeutic anticoagulation, placement of retrievable vena cava filters can prevent pulmonary embolism. Once placed, it is important to periodically access patients for resolution of contraindications, removal of the vena cava filters, and switching to the therapeutic anticoagulation. For patients with catheter-associated thrombosis, treatment consists of removing the catheter or anticoagulation if live catheter remains. Staging. We have 4 stages if you see the picture, and we have 4 stages if we talk about the types. Provoke. Due to acquired stage, surgery, oral contraceptive, trauma, immobility, obesity, cancer. Unprovoked. Due to idiopathic or endogenous reasons, more likely to suffer recurrence if anticoagulation is discontinued. Proximal, above the knee, affecting the femoral or iliofemoral veins, much more likely to lead to complications such as pulmonary emboly. Distal, below the knee. And 4 stages. Stage 1, we haven't got any problem. Stage 2, we have small thrombosis in the claps. Stage 3, we have big thrombosis, and stage 4, when we have a free thromb. Many DVT will resolve with no complications. Prognosis. Post-thrombotic syndrome occurs in 43% of patients 2 years post-DVT, 30% mild, 10% moderate, and severe 3%. The risk of recurrence of DVT is high, up to 25%. Death occurs in approximately 6% of DVT cases and 12% of pulmonary embolism cases within 1 month of diagnosis. Early mortality after venous thromboembolism is strongly associated with the presentation of pulmonary embolism, advanced stage cancer, and underlying cardiovascular disease. Complications. The following are the 2 major complications of DVT: pulmonary emboly, paradoxical emboly if an atrial septal defect is present, post-thrombotic syndrome, bleeding from the use of anticoagulations. Yeah, and in the right side you see the pathogenesis of post-thrombotic syndrome: deep venous thrombosis, valvular failure, inflammatory response, fibrosis, and post-thrombotic syndrome. Postoperative and rehabilitation care. Thromboprophylaxis strategies for hospitalized patients at potential risk for deep vein thrombosis include pharmacological and mechanical arms. In the pharmacological aspect, unfractionated and low molecular weight heparins, novel oral anticoagulants such as direct thrombin blinders including dabigatran, factor Xa direct blinders including rivaroxaban, and aspirin or warfarin should be considered. Postoperative and rehabilitation care. It should be noted that the results from network meta-analysis indicate that NOACs are an effective treatment for thromboprophylaxis of VTE or VTE-related mortality in the extended treatment scenarios. However, the complications with bleeding risk differs. Accordingly, apixaban was reported to have the most favorable profile. The comparison was published in the context of other NOACs warfarin with endpoints of inner 2 to 3 and aspirin. In the mechanical prophylactic arm, the following measures should be evaluated: graduate compression stockings, intermittent pneumatic compression devices, venous foot pumps, electrical stimulation devices. Still, mechanical devices should be applied in adjunction with pharmacological prophylaxis. Thank you very much for your attention, and please remember, if you love something, share it with everyone. Maybe it will save your life. Have a nice day. Bye bye.